Welcome to this short presentation from the Swansea Bay physiotherapy team. If you have been diagnosed with subacromial pain by a healthcare professional, we are hoping to provide some information about that condition, some guidance about what to do about it, and some useful resources for further help.
The aim of this webinar is to provide advice of how to manage subacromial pain based on national guidelines and research. It aims to share some basic anatomy of the shoulder so that you have a greater understanding of where the pain is coming from. It will provide treatment ideas so that you can manage the problem independently. And it aims to provide self-help resources for subacromial pain and general exercise. SAPS stands for subacromial pain syndrome. It's a term used to describe non-traumatic shoulder pain that is typically made worse when lifting the arm. Up to 30% of the population experience shoulder pain within their lifetime. Of this percentage, between 44 to 66% have subacromial pain, making this a common musculoskeletal condition. There are many different structures within the shoulder that can be related to the cause of subacromial pain. Commonly, these structures are found within the area of the shoulder known as the subacromial space. Such structures include the tendons, bursa, and the acromion process itself. These areas can be identified on the anatomy slide. This condition, subacromial pain syndrome, is sometimes known as impingement syndrome, rotator cuff related disorders, and non-specific shoulder pain, which all mean the same thing. In the next few slides, we're just going to take a little look at the anatomy of the shoulder.
This is a view of the shoulder looking directly from the front. From this diagram, we can identify the subacromial space. It is beneath the acromion process, which is a bony prominence attached to the shoulder blade itself. Within the subacromial space, we have rotator cuff tendons and the subacromial bursa. These structures can be responsible for subacromial pain. For further detail of the anatomy of the shoulder, please refer to the next slide. The diagram on the left is the same view as the previous image with slightly more detail in place. Here we can see the structures that are located within the subacromial space. You can identify the subacromial bursa and supraspinatus tendon. Irritation of either of these can cause subacromial pain. The second diagram on the right illustrates the rotator cuff. The rotator cuff includes 4 small muscles that are responsible for rotation and providing stability of the shoulder. They are called the supraspinatus, infraspinatus, teres minor and subscapularis. Often, irritation of these tendons of the rotator cuff can account for the symptoms of subacromial pain.
So, how is subacromial pain diagnosed? It is diagnosed using a combination of the history and physical examination. The history will include the description of the symptoms, how they originally started, and what aggravates or eases the symptoms. The physical examination will include a range of particular movements and resisted tests of the shoulder. The diagram on the right shows a painful arc. This is one of many physical tests the physio may perform to help with the diagnosis. Imaging is rarely required for accurate diagnosis of subacromial pain. Symptoms involve pain in the shoulder or upper arm, which is often worse when elevating the shoulder. This was demonstrated with the painful arc test on the previous slide. Pain can radiate down the arm towards the elbow and even as far as the wrist in some cases. Functional activities can be painful, such as washing and dressing, and it is not unusual to have disrupted sleep when laying on the shoulder. So moving on to what may be considered the most important part, how do we treat it and how do we get it better? There are numerous ways to assist with subacromial pain. Conservative treatments involve physiotherapy, painkillers, anti-inflammatories, and avoiding the most pain-provoking activities. The majority of patients will improve significantly with the correct utilization of these conservative measures. Occasionally, more invasive treatments are required once conservative measures have been exhausted. These can include corticosteroid injection to the subacromial space, and in some circumstances, surgery involving a subacromial decompression.
One of the most important roles of the physiotherapist is the assessment and accurate diagnosis of the problem. Further to this, education plays an important role, as understanding where the problem is coming from and what the problem is can make a big impact when it comes to effective treatment. Physio will also advise on what treatments are available and the most suitable treatment method for you. They provide advice on prevention of further issues, which can include lifestyle and general exercise advice. In some cases, physios are able to refer onward for injection and surgical opinion once conservative measures have been exhausted. We are going to go through some exercises that may be helpful to manage subacromial pain at home. The first exercises we're going to discuss are taken from Arthritis Research UK and are specific for the shoulder. These exercises can be beneficial when your shoulder pain is very acute and irritable, as we know that even gentle movement and exercise can be beneficial to decrease pain in the shoulder. These exercises are designed to be gentle and you should not feel a great deal of discomfort when completing these. If even these gentle exercises are causing significant discomfort, then discuss this with your healthcare professional. The first two exercises for the acute and irritable shoulder are pendulums and scapular set-in. The pendulum exercise can be completed by leaning forward slightly, holding on for support with the opposite arm and letting the painful shoulder relax. Very gently start to move the arm forwards, backwards, side to side and in small circles. The scapular set-in exercise is where you pull your shoulder blades back and together. This assists with posture and stretches the muscles at the front of your shoulder. Aim to complete these exercises up to 3 times a day. Repetitions may vary, but ensure that you start gentle and increase these as able. The next two exercises for the acute and irritable shoulder include the shoulder stretch and the isometric strength into rotation. For the shoulder stretch, rest your arm against the door frame and gently lean forwards until you feel a stretch of the front of your shoulder and chest. If this exercise causes significant pain, try altering your starting arm position. With a stretch, we aim to hold it for up to 20 to 30 seconds and repeat 3 times. Again, start gentle and work up to this number if it is uncomfortable. For the isometric strength through rotation, you need to push out against the door frame and push in against the door frame using your hands with your elbow bent at 90 degrees. Hold this push movement for a few seconds and repeat. Similar to the previous exercises, try to repeat this up to 3 times in the day. Start with gentle repetitions and increase as pain allows. If you are able to complete the previous acute and irritable exercises with ease, it is time to progress on to exercises that are a little more challenging. These progressions of exercises have been taken from the Subacromial Pain leaflet produced by the British Elbow and Shoulder Society. The link to this leaflet is available below and at the end of this presentation. The first exercise involves rotation of the shoulder while having the arm supported. Aim for 3 sets of 8 repetitions. If you can do this exercise comfortably, you can progress this exercise by holding a bottle of water or a small weight for some added resistance. The second exercise is a wall push-up. Again, aim to complete 3 sets of 8 repetitions. To make this exercise harder, try moving your feet slightly further away from the wall. The third exercise is where you're required to use a towel or resistance band if you have one. The idea is to pull on the towel or resistance band while lifting your arms forwards and up with the support of a wall. To make this exercise more difficult, you can complete this without the support of a wall. For this exercise, aim for 3 sets of 8 repetitions again. With any exercise, it is important to start gentle and build up gradually. If the exercises cause only a little pain that eases after you stop exercising, please carry on. This is expected. However, if the exercises cause significant pain and do not settle for more than an hour after exercise, please stop and consult with your healthcare professional. It is also important to note that it can take a significant amount of time to make a change in symptoms. These changes cannot be expected overnight. In most cases, we should start to notice a change in symptoms between 6 and 12 weeks following physiotherapy advice. We are going to discuss a little bit about corticosteroid injections, as these can be helpful for the treatment of subacromial pain. One of the main reasons people experience pain is because the tissues in the subacromial space, such as the bursa, may be inflamed. The pain is often worse at night and on certain movements. In these instances, a corticosteroid injection combined with a local anaesthetic is often useful to reduce the inflammation and pain to allow rehabilitation to take place. It often significantly reduces night pain and improves the quality of movement. The benefits can be short-term or last for several weeks or longer if the right tissue is targeted. The injection also helps confirm the diagnosis of subacromial pain. If the pain returns after a period of time, it can be repeated, but the NICE guidelines do not recommend more than 2 into the same spot over the course of a year. What happens if it doesn't get better? It is worth noting that if done correctly over a long enough period of time, conservative measures have proven to be effective in reducing symptoms of subacromial pain. If an exercise program has been followed for at least 3 months with no improvement in pain, then a referral to a shoulder clinic is possible. Investigations will be done to rule out possible other causes for the pain, for example, rotator cuff tears or calcification of a tendon. There is little evidence that surgery for subacromial pain in the form of a subacromial decompression is any more successful than physiotherapy with or without a corticosteroid injection. I have provided some links to some useful shoulder resources. The first one is advice provided by the Chartered Society of Physiotherapy. You will find the link to the acute and irritable shoulder exercises here. The second is a link to the subacromial pain leaflet produced by the British Elbow and Shoulder Society. The third is a link to the British Elbow and Shoulder Society's YouTube channel. Here you may find further advice and exercise guidance for the shoulder. We have discussed the importance of shoulder-specific exercise for subacromial pain. We also know that general exercise plays an important role in pain management. This could be as simple as a regular brisk walk. Follow the link under physical activity guidelines to take you to the government's advice for physical activity. On a weekly basis, we should be participating in 150 minutes of moderate intensity exercise or 75 minutes of intense exercise. Exercise should also include strength and balance. For information on the types of exercise you can try or how to get into exercise, follow the NHS link at the bottom of the page. Following on from getting into exercise and living a healthier lifestyle, if you would like any information on quitting smoking, please call the number provided or follow the link to the Help Me Quit website. To summarise, subacromial pain is a common musculoskeletal complaint and symptoms can improve with time and exercise. Please be patient as symptoms can take between 6 and 12 weeks to show noticeable changes. Subacromial pain should be treated with exercise, painkillers, anti-inflammatories and avoidance of aggravating factors as the first line of treatment. And we also know that living an active and healthy lifestyle can benefit you physically, mentally and assist with pain management. I hope this presentation has been of some benefit to you. Best of luck with your rehab, and if you have any major concerns or issues, please discuss these with your physiotherapist or healthcare professional. Thank you.